Good morning and welcome to our monthly webcast. This is session number 52. I am Samir Mehta, your moderator. First of all, my welcome to the numerous interventional cardiologists who have come online from the Russian Federation. Congratulations also to Professor Yevgeny Shlichtov for organizing the superb 50th course of the Russian Society of Cardiology. I'm also delighted to note that this is a massive country with some major infrastructural enhancement, deep governmental support for the PCI programs, and we wish you well. I would also like to congratulate Professor David Yosiliani for his tremendous first STEMI course in Moscow, and finally welcome also to Dr. Tatiana Kurko. With these words, let me take you to the cardiac cath lab. I remember vividly from almost 4.5 years ago when the first couple of cases we did with the live cases were performed with the left ventricular assist device. Many changes have occurred, great innovations, major improvements have occurred. Let's go back, show you once again today a complex coronary intervention case with left ventricular assist support. Samin, good morning.
All right, good morning to all our viewers from Mount Sinai Cath Lab with my staff here and Anu on my left side. And we, as you mentioned, goal will be to show, because majority of the cases we do without any assist devices, that the assist devices are essential in a busy cath lab, and it's very important that we continue to do well in those tough cases. So having said that, this patient actually, if we can go quickly and then we'll have a little time, that this patient, if we can get the slides, good. Support, you see that every month the number of our grant supporters continues to increase, and with the St. Jude's, Abiomed and Vascular Solution and Bracco Diagnostic, the recent entry. And this is a 79-year-old female who had long-standing history of CAD. A few MIs, bad LV dysfunction, came last month beginning with non-STEMI. That time was catheterized, and we'll show you the cath, and on a great, on good and optimal medical therapy, and patient has gone through various carcinoma treatments and so. 3-vessel disease, EF is 22%, and Anu will take us through the angiogram quickly.
Okay, this is our left system. Left main is okay. Prox LED is calcific but non-obstructive. After the second diagonal, which is mid to distal LED, you have significant disease. Your two diagonals, first diagonal is small disease, but second diagonal, which is at a bifurcation, again has a disease. And if you go to the circumflex,
and it's a moderate calcium there,
yeah. The prox circ and entire circ is okay, but you have the LPL, which are OM2, which has significant disease. Yeah. And this is her EDP. She's, on Lasix and other good medical therapy for her LV dysfunction. EDP today is 12, but she has LV dysfunction with the EF ranging about 25% or so, but most of the dysfunction you see in antro apex and infrabasal area. This is a right coronary artery, moderate calcium tortuosity in the prox, but just after the RV branch you have a significant disease, but most of the disease, which is calcific and about 15 millimeter eccentric calcific disease, just at the angle of the
level, at the angle. Now coming back to our slide presentation, and this really is a challenging case. 3-vessel disease, EF is around 20-22%, came with a non-STEMI at that time, although syntax score was 23, so it's a reasonable to try do the culprit vessel PCI, and that's the time they try to do the right coronary, and after advancing the wire, no balloon crossed, so it was aborted because patient started having chest pain, put a balloon pump after the procedure, and patient did fine, stabilized, no subsequent CK. Now since then patient continues to have symptoms despite the maximum medical therapy, and purpose there today is to bring patient with for calcific RCA and mid LAD, maybe leave the circumflex alone, use of with the Impala assist device, and of course this one will make it in the appropriate criteria very high up. So now Anu will take us that let's do this Impala. while the impella is done and we're getting to the angiogram and PCI of the right coronary, which will require rotablation, we'll go through the step-by-step one of the impella insertion, and then we do the actual PCI.
Samin, quick question. Was the previous attempt of the PCI of the RCA done at Mount Sinai?
Yes, it was done at Mount Sinai. They were concerned about doing a rotablation in the setting of myocardial infarction. Okay. And of course, as we have published that even some calcific lesion in acute coronary syndrome, non-STEMI, rarely we have done handful of STEMI patients because nothing else will go. Use of that advance the rotawire and use 1.25 bar. But it was reluctance, and we could have done it few days later, but patient was okay on the balloon pump, and we stopped at that point. Yes.
Excellent.
Go.
Yeah, I think if you can show the groin shot before we do any kind of a closure, assist device, we have to make sure your femoral artery, iliac are okay and can take this device. Even if they are calcific torches, you are able to do it, but as long as you are very cautious. We have even done this device through abdominal aortic stent graft. If you see, I think the fellows are here well trained to do pre-close. I have Bhupati, we can show Bhupati, Rahul as well as TT, our 3 interventional fellows. Yeah.
3. So maybe 2 would have done better than 3.
But
yeah.
So if you see here, what they do is they take a micropuncture kit, and with a 4 French, with just the first injection, we knew there was some dissection from the previous procedure. So we thought, let's go to the left side. So they went with a crossover catheter, and the artery looks okay. But if you see again, the bifurcation is high. They had to get a this was the first puncture, which was just at the level of the bifurcation, not comfortable to do the 2 per close at that level. This was okay, but as we did the first pre-close, what you do is check the pulse as you're doing the pre-close. Pulse was faint, so we took it out and just went with the sheath on the right side, so on the left side. So right now we will have our procedure sheath on the left side, and when we decided, we'll do the impella on the right side. If you see, we have the 14 French sheath with the 2 pre-close already done, and we have the JR catheter, just a regular JR catheter already in the LV.
Anu, excellent demonstration of the access issues, and now I understand why there was a 10-minute delay before we could start. You were trying to decide which groin possibly to choose.
Yeah, I mean, since pre-close, at the pre-close, that's a very key point in the sense that when you are doing the pre-close, the nurse is checking the pulse, and if the pulse becomes faint, which means your probably foot plate has picked the posterior wall or something, you just abort at that level, do nothing. You see, we took another picture, the artery is still okay. We went on the right side, so that thing took us a little bit time to just to get a pre-close right. And once we have the catheter, you just take your platinum wire all the way. If you see, we are going to do the impella CP, which is cardiac power, which can go up to 4 liters. Also important, as soon as you have your sheath inserted, you have to have your anticoagulation going, whether you decide on heparin or angiomax. We actually have angiomax, and our ACT is about 320. As long as your ACT is about 270 on heparin with the long sheath in, because you cannot have this 14 French sheath without any anticoagulation, because you can have clots formed within the sheath. This is the same. This is a 9 French catheter, and you have this pump which is at this level. What was the modification they had was this red tube, so that as soon as you insert the wire into the pigtail, your wire exits at the right spot.
In the past you used to bend, and so here you not need it, but it's still...
yeah, it's still not coming.
What happened?
No, it's came out here.
Right?
Mm-hmm.
No?
Yeah, excellent job. Okay,
all right,
now
we'll
hold
still
it.
go with the low. Yeah.
Okay, good.
Good. Yep.
No, 1 second. It's not parallel. It has to be parallel to this black line, which means you have to come back and hold it like this. Same, it is exiting everywhere. So now you see it is parallel to the black line as long as your exit is, you can see that, right?
Yeah.
That's good.
Okay.
So this is a 14 French device?
14 French, yeah.
The 14 French, that special sheath, and the device 9 French.
Mainly because of the pump which is at this. Now when you're going in, you have to be careful. Again, there will be a lot of bleeding. So if you can go in quick, here it bleeds a lot. Good. And just advance slowly.
So a large pigtail catheter, that is all you have?
That's it.
And let's
Once you are in
approximately
the LV, you can just pull back the wire.
10 seconds to deploy, huh?
Yes.
Samin, how many cases does one need to practice before does this? You're ready to go with almost the first case?
Yeah.
See one, do one.
Yeah,
That's it.
That's exactly what it is.
And they're focusing on the console right now, which will explain everything as long as you know to read English, or if you can do it in Spanish and other languages, right? To get it all over the globe. So it will tell you, it primes and it will. We are okay? Positioning wise? Yes? Okay.
And then all this prime pumps and everything comes handy so that it's all ready. In the past, you used to have this dextrose solution, everything comes very simple and easy as say that we are ready to start. And that actually has shown with the recent trials of the Impella insertion time, balloon pump takes about total to get ready about 90 seconds and so, and Impella takes maybe just double the amount, 2 to 3 minutes for fully ready. And this is exactly, you saw it in this case, actually we did even less than a minute.
Samin, there was a practice in the past to guide it with the use of also putting in a swan. No need absolutely now?
Well, I mean, in the trial, but I think in some cases where patient really have a bad hemodynamics, hypotension, do you think it's a mitral regurgitation, patient EDP is high, guiding with the swan will be reasonable, but not routinely. So if we take out of the PROTECT 2 trial, which required putting a right heart cath, in our day-to-day life, we use a right heart cath in maybe in about 1/4 of cases. It's not routine anymore.
So if the access is not an issue, age is not any barrier?
Yeah, that's correct. No. Because this is older, these patients, many of them are the ones because of extensive CAD like this patient, had few MIs and just come back here for intervention finally. So that no age is not an issue. The access is the key point. That's the biggest issue in these patients. Like this patient has few MIs, but till age of 79 did not go for any cath. And finally, because of few MIs and accumulated LV dysfunction, went for cardiac cath.
Anu, was that water or Red Bull?
That actually water. No, we don't drink any of those things. I don't even drink coffee.
Good. Now with that note, while we are getting ready, this is the Shepherd Crook right catheter of Medtronic. SCR, you know, anytime you have the upward takeoff of the right coronary, you can use the AL 0.75, but we found the Shepherd Crook SCR. It's both 3.5, 4 and 4.5 available based on the upward and gives you very good support. So this is what we are using now. Very heavily calcific lesion. I'm sure you can appreciate that. Also LED is very heavily calcified, and this is where goal will be using a fine cross and fielder wire, change it to rota, and meanwhile within next 10 minutes I make my presentation of the 2 points, and then we'll be ready for rotational atherectomy.
You want me to wire it?
Yeah, the wire we can do. All right?
125.
Yeah.
But don't open, have it ready because...
Yeah, maybe 1.5. Yeah, you come inside. Okay, now we can go back to our slide presentation so that we just make two important points today. Like every time we try to make it and give the latest what is there in the literature. One is the LV support for high-risk PCI. And second point is the appropriateness of PCI in stent use, which have come into the limelight again by the Bloomberg News and Heart.org in last few weeks. Now, LV support, we have 3 balloon pump, PTVA tandem heart and Impala with a recovers 2.5 or CP, which is 4, and then we have Impala 5, which is a surgical cut down. So 2.5 and 4 are ours percutaneously and so. Now, in difference in balloon pump and Impala basically is in their the pressure loop curves. Key is that the balloon pump basically reduces the diastolic volume and unloads the ventricle. And therefore the balloon, the Impala, the balloon pump increases the stroke volume and of course reduces the systolic aortic pressure. But this really work the contradictory in many times in the balloon pump cases. Therefore, it's a I'm sorry, you want to say something?
No, so when I'm wiring, it can be shown in the side.
I see. Yeah, I think no, not with this, not for the slides, not slides. Yeah, the question was the wiring is if there is any difficulty comes, we'll come back to the point. But the key is that the both balloon pump and therefore in the conditions of the LV dysfunction, really. Your Impala will give you better hemodynamic support. And as you know, the landmark study of the PROTECT 2, which showed some trend in all cases. Once you went to the 90 days, trial was aborted earlier than expected. Now, actually, if you want, wait 1 second. Why don't we just stop here and let's go to the crossing the lesion. Tell us what we are doing now.
No, I have a fine cross and just a fielder wire. If you see the picture, there is a lumen there.
Okay.
So you just take your any kind of a glide wire with a fine cross, so we're able to get through that fine lumen. The question is whether we will be able to get the fine cross across. If that's the case, then we can exchange it to the rotor wire. The question is what kind of rotor wire you think we should be using, floppy or I think we need a floppy rotor wire only.
Yeah, the floppy wire will be good enough.
Right.
And now we are and you see that this combination, go with the over the wire, I think we can do 1.5 bar. Get ready 1.5.
No. It will call gutter, no?
No, 1.5 will be okay.
Gutter?
Yeah, a little bit good. Huh?
Gutter. See the...
Yeah, no, question is 1.25 or 1.5. In my opinion, how your the fine cross went. I think you need to do a little debulk, otherwise you will not be able to open. So that since it went easily, and we are going to change, now this, okay, we have to take the wire out, and we are going to use the rotor wire and exchange now and go to 1.5 bar. If would have been a difficulty getting the fine cross, then we would have gone with a 1.25 bar. So meanwhile, we can come back to our slide presentation while we are getting ready for the rotational atherectomy in this case. So therefore, overall, if you say, the PROTECT 2 trial, by definition, because you stop the trial because of lack of benefit, I would call it neutral. Not harmful, but neutral. Now, having said that, if they really would have gone a little longer, there was no question in my mind that the trial would have been positive. Now, see, these are the data of the 90 days, 30 and 90 days of major adverse endpoints. And of course, there were the 9 other individual endpoints, which I'll show you. And that is that if you go with the per protocol, these are the points: death, MI, stroke, repeat revascularization, vascular complication, acute renal dysfunction, severe hypotension, VT, aortic insufficiency, and angiographic failure. Now you can see there individual endpoints that if you go with per protocol, patients who received the Impala in the trial PROTECT 2, they had a significantly lower these endpoints at 90 days compared to balloon pump. And the most important difference basically was lower repeat revascularization. That basically means Impala allowed us to do a good intervention, so less patients came back later, and the rest of the endpoints, the death, stroke, and so were not different, and vascular complications were just slightly non-significantly higher. But overall, the important point is that by doing an Impala, although it caused a little more costly in the beginning, by decreasing the repeat revascularization, on the long run, it did benefit. It decreased the overall cost of the interventional procedure. So this is a very, very important point which I wanted to emphasize on this 90-day outcome. Now, second is, they're very important. This is another device which is dependent on experience. And clearly now we have the better already primed device and so which is very easy to do, less timing, and so that over the time in the trial, from 2008 to 2010, you can see while the balloon pump outcomes were identical, remained same, while clearly there was a lower the event rate in the Impala group. So clearly that experience does count when we are talking about the Impala. Now, then there is what about understood in the high risk? Now, what about in shock and inoperable cases? So we have the data on the Impella Euro Shock registry of 120 patients, but it turns out to be that we can use Impella, but it didn't do much in my opinion, because the mortality rate at 30 days remains 64%, and that's what exactly we had in the shock trial and any of the newer data. Now, of course, rest of the complications are shown, but it does improve the hemodynamics and the pharmacological parameters of the plasma lactate and so. But really, it's not a randomized trial. But if you go by the registry, I would say probably similar mortality at 30 days. Now, then question is, what about these devices, whether Impella or balloon pump patients from the cardiac arrest shock recovery? Now you see their identical outcome whether you put a balloon pump in this study versus Impella. Then the lastly remains that is there a difference? Again, in a non-randomized, this is the data from the registry again, in high risk or cardiogenic shock, seems to be the balloon pump and Impella did not make any significant difference. Similar data which we have in the PROTECT trial, but clearly the PROTECT 2, really we started seeing the benefit at 90 days. So once you go out, in my opinion, Impella will be beneficial in these high-risk patients. Now these are the various studies. Actually, our study also by Kovacic, where we presented 68 patients with the tandem heart or Impella, and our conclusion was that Impella is easy to use, took less time, and despite a high patient baseline characteristics, that did equal outcome as of tandem heart. So tandem heart kind of disappeared, in my opinion, from the interventional cardiology, and rare case where you have an aortic valve issue or the LV thrombus, probably you'll go to tandem heart. Otherwise, Impella gives you enough results, and there's no need, in my opinion, for the tandem. Now this I have put it together, that how do we use these devices based on the LVEF and the lesion complexity. If your EF is normal, that you probably don't need support. In some complex cases, may need a balloon pump. Once your EF is moderate to severe range of 20 to 35%. In simple cases, I believe that balloon pump is good enough. And complex cases like high syntax score, 32 and more, STS mortality high, extensive revascularization, multi-vessel revascularization, Impella will give you a great help and will allow you to do your intervention properly. And lastly, in the severe LV dysfunction, when there is no other option, inoperable, so you need to come out, make the patient, let the patient come out alive from the cath lab. Impella will be a very good device to work, and of course some cases can be done PTVA. Just to give a snapshot that what we do at Mount Sinai, of the 400 PCIs every month, approximately 25 balloon pump, which makes it 6.25%, and about 4 to 5 Impella, about 1% are used. So clearly you use it in the right patients. Now we have actually another device which is portable ECMO. That is cardiopulmonary bypass support in the cath lab with in really tough cases. And we had done one case. It cost about $100,000. Market is the company, but it's available so that every lab which is performing complex intervention, in my opinion, should have this portable ECMO in the lab, because so that you don't have to dependent on the surgical emergencies, and you can do it, insert yourself percutaneously. The second quick point of the appropriateness of the PCI, why I took this point, because this is very close to my heart, and we particularly at Sinai, we practice by the appropriate guidelines since 2010 when the data came, because recently again in the news that surfaced, the death linked to cardiac stent rise as overuse seen. And this is there is a 4 minutes video in the Bloomberg. Actually, I was interviewed in last 45 seconds, and I clearly defended that if we do it right, that clearly it will not be an overuse, it will be the appropriate use. Now how? We now have the guidelines of 2009 and 2012 of appropriateness use criteria for coronary revascularization. And despite that, what has been known now, that if you go with the ACC NCDR, that about in stable patients, which is in yellow, about 12% of patients had inappropriate PCI. Now, and clearly in acute coronary syndrome, that number is very small. Now, which patient gets inappropriate PCI? That's what basically we need to figure out, so that we can change our practice. This paper will be published in next 2 months, and it's available now from Chen, same the author of the previous the JAMA report, and basically showed that which patient will get inappropriate PCI, that man, white race, private insurers, and urban hospitals have a higher incidence of inappropriate PCI. And actually the other outcomes are shown here in this slide, that if your on-site cardiac surgery did not make a difference, but if you're doing a more number of PCI, chances that you'll do inappropriate PCI will be much lower. So clearly we had to be very careful what we do, and they had to be justified. Now, there is a wide variation. This is the data of the 2010 from New York State. Anywhere from 3% to 50% of the inappropriate PCI in New York State. And Mount Sinai with the 3.75%, one of the lowest as shown here, while average was 13.4 and it became 3.7 for Mount Sinai. Now 13.4 was because of the Sinai having a large volume of the 14,000 you can see, 2575 from Sinai. If you take the Sinai away, the overall inappropriate PCI in New York State was about 18%, similar to what is going on at present in the ACC NCDR. That inappropriate PCI, last year we became a part of the cath PCI registry, 19.9% in the US hospital. Mount Sinai was 3.1. We did even better this year in 2013. Now at Mount Sinai, 1.7% of the PCI are inappropriate, while that number remained 19% for the rest of the US hospitals. Now clearly one of the more important drawback or the factor of the inappropriate PCI is a suboptimal medical therapy. And this actually seems to be that despite the courage and the data, that practice has not changed. So we need to do better job in terms of optimizing medical therapy. Now then I'm going to show two sets of data. I say, okay, you decide appropriate, inappropriate, uncertain. Does it matter? And this is actually the Canadian study, which patients were classified appropriate, inappropriate, and uncertain, and the individual distribution of the technique, CABG, PCI, or inpatient. You can see once you are appropriate, large number of patients get revascularization. If you are inappropriate, large number of patients get medical therapy, which is the right thing to do. But can you show the data? And this is the very interesting 3-year endpoint of death and ACS in these group of patients. 3-year endpoint, and you can see that if you are appropriate, you do revascularization, you have a lower outcome. If you are inappropriate, and if you do a revascularization, you see that your outcome is higher. So clearly it makes sense that appropriate cases, if you don't revascularize, which is the yellow bar, if you don't do revascularization, your event rate is higher of the death and ACS. So point is, the making it appropriate makes sense, and all appropriate PCI should be done. So coming back to the point, use of stent or not stent, if it is appropriate, it's shown to be decreasing death and acute coronary syndrome and should be done, but clearly by the criteria having appropriate. Now also the second point, this is the data from Ron Waxman's group, that appropriate, inappropriate, and uncertain is the same in hospital mortality. So the first bar is the appropriate, second is the red bar is the inappropriate. Inappropriate has a higher complication, and same on the multivariate predictor of a higher event rate of 30-day in-hospital 30-day or in-hospital mortality. So clearly it seems to be that if you do it appropriate, that you can really neutralize this whole issue about the overuse of stent, because you are using it in appropriate cases. So also the CMS has started that if you are inappropriate, hospital should not be reimbursed. So that those 13 to 19% of cases are at a stake, that hospital will lose money because will not be reimbursed by the CMS. So therefore, I think the best answer for us as an interventionalist is to change the practice, work by the guidelines, and that exactly my interview on that is that we are very cognizant nowadays what we do at present, and with the goal that do the right thing to the right patient, so that sometimes you may need to use stents in some cases which other people don't want to, but as long as you are working with the appropriate guidelines, and we showed you the data at Mount Sinai with a large number of patients with the 4,000 plus cases done every year. The number is 1.7, less than 2%.
So,
and with that note, I stop here and we'll start our intervention.
Excellent review of two very pertinent issues. So now there are 3 sets of guidelines which we follow. Yep. There is a ACC guidelines for PCI, there is a SKY guideline, and a Bloomberg guideline.
Yeah, that's a very important. I would say the third guideline is the most important, because the media frenzy, this was on the heart.org also. And so, but key is that also we need to be careful by these reporters that they try use the data to their story, fit the story, rather than really present the science.
Right.
But clear, I think in this, the whole article, although there was a lot of emphasis on inappropriate use, but at the same time, they were honest enough that yes, if you change your practice, do it right, probably it's good for the patient.
So now what is going on here, we have the rota burr.
You chose 1.5 or 1.25?
Yeah, 1.5.
Okay.
Right now we are 1.5. Of course, the concern was creating the gutter effect in this tortuous vessel, but then we'll see. Yeah.
I'm trying to get the burr in. So if he has a push-pull,
six French.
Okay.
Yeah. Go.
If we have a trouble in getting the guy, as soon as I'm trying to bring the burr in the proximal part of the RCA, you start seeing the guide, pushing out. So the goal in this kind of situation is don't get too aggressive. What you do is go on dyna, and your assistant will help you push the button, and I'm going to just go forward with dyna. And how do you do this movement in the proximal part? It has to go in a little bit. Okay.
Yeah.
So I'm just going forward.
Yeah.
Good. So now the burr is in the proximal part of the RCA. We haven't caused any trauma. We knew that there was no lesion at that level. And from here, actually, if you have already done the dyna, we don't have to do our 3 steps. But still, you can do your 3 steps quickly and start burring from this level.
Okay.
So the burr speed is about 130. Same slow pecking motion. I see a drop in the RPM, you can hear that. You want to give some dive?
Yeah, because if any time we see the difficulty, then we can always, I have very low threshold of changing to 1.25 bar.
I think we should.
Yeah. Good.
It's a lot of wire bias there.
Good. Get a 1.25 bar ready.
Yeah, it's ready. Yeah.
Otherwise it will not do any rotation.
45.
No matter.
42.
Your first lesion has been crossed now.
47.
Yeah. And every time you have to pull back from the proximal lesion and then let it rest. Yeah. And you see the guide, the hand on the guide, and then the gradual advancement.
Angle assess, we should not push it.
Now you tell whenever you feel like that we need to go to 1.25, we can go to 1.25. But I think things are going okay. Let's because it's the tactile feel, we have to say. Yeah.
Not making that turn there.
Huh?
I think I said the vessel. Take it out.
Okay. Get a 1.25
So,
bar.
I mean, that was a very nice observation you made. I think viewers should benefit from that there is this certain tactile feel to it, and you start getting that feeling that probably time to undersize. Yeah, Anu, go ahead.
Other thing is also, once you see that kind of wire bias,
Right.
Even though the fine cross went, I mean, just taking or doing a 125 burr and taking a shelf of the calcium from that tight lesion should be enough.
So, I mean, I have not used this Shepherd crook, but it almost looks like a hockey stick catheter.
Yeah, but
It's more, I think,
points up.
Yeah.
But you're right. It's a hockey stick. Actually, you know what? The hockey stick we used to use quite a bit. Now between the Shepherd crook AL 0.75 and the Lima guide, we never used.
Right.
We rarely use now. There still some cases are there. We use hockey stick, but we go. Actually, you know what? Why can't we bring one Shepherd crook
to show the shape?
Show.
Yeah.
It's a very nice. Now, similarly, Boston Scientific have the called Voda Right.
Right.
But I found it is very aggressive that Voda Right actually goes to the mid vessel compared to the left-sided Voda, which is very good, which majority of our interventions are done using left, VL.
Well, the whole EBU came from the Voda catheters.
Yeah, exactly. Yeah, show that camera-wise, if we can show this. Yeah.
No, down.
Yeah. So it's a little upper takeoff. That's the advantage.
No, plus your secondary curve, you have more support.
Yeah.
Right.
Yeah.
Go.
Don't do anything.
Good. The same 150 outside, in the body about 140, and so low speed burring will cause less wire bias, less dissection and perforation.
I think we have to go a little higher speed.
Yeah,
maybe.
and then if you cannot cross it, then you can go to 160, 170. It's still push and pull effect is still, because over the wire exchange length.
Like here, you have some resistance.
Good.
Yeah.
So you'll go with Dynaglide or?
Yeah, I will go with the Dynaglide. Let's go there with the Dynaglide, right?
Right there. Good.
Good.
Go
See
to
that
little
drop
more
in the-
speed, guys. Go to 140 at least.
As soon as you are reaching the lesion, there's a drop in the RPM.
Good. Good.
41, 20 seconds.
And 20 seconds is our limit. You wait and then go back again.
Go a little high speed.
No, one.
Yeah.
Yeah. We need to go little, maybe 150 plus. Yeah. Go. Yeah. Go to 150.
Little higher. Good.
Good.
I don't like the noise.
49, 48,
Oh, this is that called calcific.
46, 51, 20 seconds.
Yeah. Yeah. The key is that it's a very risky rotational atherectomy, but there is no other way in this case to open this lesion. So we'll try as much as possible. Now, also I always say, once you see that you have ablated little part of the calcium, don't have to go all the way. That will be good enough to subsequently crack by the high pressure balloon.
Or maybe the lowest size angiosculpt or something.
Oh,
No, I don't think angiosculpt will make a
Will
turn
go
here.
there.
Turn,
Yeah.
yeah.
Okay, we are able to get through
You
now.
advanced a little more there, yeah?
Yeah.
5 seconds. 45, 49, 49, 50.
But same, take your time, no rush here. If the blood
The
pressure
pressure is
goes,
dropping. No
pressure
pressure.
despite impella, now you say, well, it probably doesn't matter with the impella because if you're having a non-cyclic blood flow with the impella. But I don't know, visually, to me, still looks...
We are going up with the output. One other thing is, I think she's becoming pacer dependent. As soon as you lose a atrial kick, she has a single chamber. Yeah.
How much is
She
the
becomes-
augmentation you have?
How much augmentation we have? 2.8. Well, she try to get a little more once you use a CP.
Yeah. She want to go
Try
up.
to get like 3.5.
You did give some fluids, right? Because the thing is also important. You need a good EDP before you start sucking more blood.
Yep.
Anu, what is the comfortable range of EDP you feel?
He has to be above
20 to
about
25?
16, 16, 18. We were 12. That's why we gave some bolus fluid here.
41, 5 seconds. 42, 33.
Same thing. You see, it's called pecking motion. You don't come back too much. Oh, whole thing was turned.
But it's go.
Like why the guide was coming out.
I was advancing the wire a little
Okay.
further. Yeah.
46, 45.
Can you go at a little higher speed, please?
Go there like 160.
But you see that it's a total wire bias. It is just doing at one part of the vessel in the inside part. Yeah, go. Good, good. I think we should come out SS.
54,
No?
5 seconds. 54,
I think just the lower part.
55.
Oh, good.
But
There you go. Went through the lesion there.
now you're going to polish and Sinai.
Yeah. Excellent job.
Now you can see that how the wire is, so that we have to be very careful. We have both the wire.
Run through wire.
So, I mean, the predominant issue there was the wire bias. So why should the higher speed help?
Oh, because of calcium. No, the idea is that efficiency, rota efficiency goes down at 140, 150.
Right.
There is no question. And this actually the data, our experimental data with Williams, one of our fellow back in 1999, we had the experiment with in the tube with Dr. Barry Kohler and asking Dr. David Oth in our paper of the slow speed back in 2002 and so that the efficiency goes down. So when he came up with the speed of the originally recommended speed of 180 for 1.5 to Burr, anything less than 1.75 and 2.0 and 2 plus of the Burr speed of 160. It came by his own data, which he did on the bone experiment to get the full efficiency. So we have seen that it may take a little extra time, but you'll cause less injury to the vessel, less heat generation. That was the data done by actually Mark Reisman, and less platelet aggregation with the slow speed, and what we have seen, less perforation. So clearly that we will increase the speed only if you could not cross the lesion with the, and see the wire and everything goes very easy. What is this now?
Absolute excellent demonstration. I know the hesitation you were having, and I know many people would have given up there as the lesion was confronting the...
Good. And second point now, that people will say, well, you already have 1.5 bar. Yeah. Why don't you use a 1.5 also on top of 1.25? Well, we say that, you know what, it may be needed. We'll leave the rota wire. We cross the lesion with another wire, and we'll see if we cannot open it, then we'll go with the 1.5. Because if you can open the lesion, there's no need to be hero, and that you need to go to the bigger bar or so. We are okay?
Yeah.
2.5 or 3.0?
This is
3.0.
3.015.
Excellent.
Quantum apex.
Yeah, so obviously
good. Opened up at 8 atmosphere.
Yeah, it would have.
Let me just tell you. We need a guideline here. Things are not going to go.
Okay.
We have this.
Would you be dilating the proximal area?
No. If you see the picture now after we did the rota, because of the wire bias, I think you have to stent the entire area now.
Of course. Go. Good.
Samin, what do you think have been the larger enhancements of in the Impella catheter?
I would say that basically the ready pump, the ready setup. To me, that is the biggest thing so far. And whether wire advancing from the back here, let me dilate here. Yeah, that wire introducer. But key, the pump priming time decreased significantly. To me, the biggest advances. So ready-made kit. Now you have no delay.
You had the chance to use it in some cardiogenic shock patients.
We actually, that's a very interesting, somebody else asked when I was in the meeting in India, and so we have not used this Impella in cardiogenic shock at Sinai. We actually have used 1 or 2 cases where the patients had a cardiomyopathy, severe hypotension, and so while waiting for the transplant. But per se in the cardiogenic shock, we are not used. We have used few cases in cath lab catastrophe, but I can tell you there has not been a great outcome. And I still don't know, from my point of view, that truly this device is going to help in cardiogenic shock, because there is no data at present to support that using the Impella has decreased or even a signal of decreased mortality. And they were supposed to do their own trial, which was aborted. So, but to me, the role of the Impella is in high risk complex PCI. Anecdotally, people may use it, but I can tell you based on the available data, I cannot support the use of it in these cardiogenic shock patients, and so based on the available literature.
Well, all I can tell you as a guiding point of some value to operators, that if you are using it for STEMI with cardiogenic shock, more important to put the Impella first and then go after the culprit lesion.
Go. Now, what stent you are going to use?
We just mentioned that we have not used cardiogenic, Impella in cardiogenic shock patient.
The Promus element.
Actually, getting cardiogenic shock patients, now the door to balloon time is going down significantly, even with on transfer patients. So we, for this year of 2013, we have not seen a cardiogenic shock patient.
So what is your catheter, your stent of choice, the most deliverable, the most trackable stent?
Yeah, well, I mean, now after you're done, and particularly with the calcific, trying to talk about the stent with
the balloon?
Huh?
Balloon.
The stent, let's see if it goes.
No, it won't.
Stent with the most, I would say, strength and support that we decided, and many cases, actually majority of, I would say, my rotational atherectomy cases, then we go with the Promus element. Huh?
Single long stent or
yeah,
two?
I think if the guide
All
liner
depends,
can go further.
guide liner and give me a balloon.
Yeah, okay, give me a new balloon. What balloon you have? Okay, good. Give me a 3030 long balloon. Yeah. Yeah, because guide liner does not fit. You know, the lumen of these guides are much smaller than our mark guide. So Sherpa, these are the Sherpa guides. So the lumen is what, 0.70 compared to 0.72. Look into that.
0.70.
Yeah, 0.70. See, so therefore even the guide liner has a very tight fit. We had removed the rota wire already. So now we need to just dilate that area, prepare the vascular bed.
Now this is 3.5?
3030.
Samin, I have a note passed here. You had a very successful top 10 cases seminar last week.
Yes, there's 150 plus people, clinical 10 cardiology topics, fantastic, and will be available at our, we'll make all the lectures available. Anybody can download the lectures from, Dr. Fuster, Dr. Sept, Keeney, myself, Narula, so that the top 10 lectures, so that we'll put a link to our CCC website or maybe through the CardioSource, but they can download those lectures from there.
Useful links to become a good cardiologist in addition to a good interventionalist.
That's it. Now you see that what Anu is doing, that on the balloon, advancing the...
you have the stent ready?
Yeah, advancing the guide liner.
Right.
Yes. Actually, they have come up with a new device also, Godzilla. Maybe we should have, we have it now.
From Boston Scientific.
Yeah, Boston Scientific. We should have tried that one. Today with the test of the Boston Scientific devices. Rotablation, their balloon, and could have been a Godzilla, but the lastly is the stent. Yeah. Average flow now, I was told, is 3.2.
With the impella.
Yeah.
How long are you leaving the impella in?
All our cases we have removed post-procedure in the lab. So
actually, once we deploy the stent, everything is good. They know they automatically start.
Irrespective of the ACT, because you have the pre-close there?
Pre-close, yes.
What's that? 3.5 you do?
It's a 3.5, 38. Right?
I mean, a very
Promus element, real test of the stent, yes.
No.
very exciting development coming for CCC live cases. November 19th, we are starting the Spanish simultaneous translation.
Fantastic. Yes. That is, we have been working on it as with yours and help with Ricardo and so that clearly that adding new this translation will help us, our viewership, because the idea is to become globally.
Just to increase our viewers' appreciation of this, this is not the easiest of tasks. We've had Nancy, our translator, in the other room, and we've continued to practice that, improve upon it, and hopefully next session number 53, you'll have a simultaneous translation.
Too big. Long, no?
That's okay.
It's 38, is it?
Yeah, 38, very good. You want to go 2 millimeter further. That's it. Just 2 millimeter, and we are okay.
I thought it was okay even there.
Good. Yeah, it's good. Okay, we're going up now. Okay?
Yeah.
What was the size here?
It's a 3.5, 38, and go to 16 atmosphere.
Okay.
So these balloons, with this stent balloon, you can take 16 without causing overhanging, as you can see. And do 2 inflation, so the stent expands to its basically more spherical. And then if we need to go post dilate, I think it's a very large vessel. we can have a 3.75 20 millimeter high pressure balloon.
No. Looking good, no?
Yep. Yeah.
Looks good, Lee.
Yeah, but we'll see if it's necessary. Yeah. Go.
Cut the vessel.
You want to pull back? Okay. We take one picture.
Looking good.
Very good. Yeah.
Samin, going back, there is a very intriguing question I have. I'm sure many viewers will benefit from that.
It's an advantage of
Your appropriateness or inappropriateness use was very low to start with, 3.5, you brought it down to 1.7%. What were some of the steps? Just a very rigid adherence to the criteria, just a very, it's not the easiest of the tasks to monitor the appropriateness in a catheterization laboratory. How did you do it?
The very important point, take everything out, yeah. The very important point was that one, education of our referring physicians. Second, that when the case is being scheduled, clearly asking that at the time of scheduling that whether patient is on, unless patient has a severe ischemia, is patient on double ischemic therapy. That to me is the very important difference. So therefore, right at the time of scheduling, our nurses, nurse practitioners getting involved and try to make sure that if patient is on double, not a dual antiplatelet, dual anti-ischemic therapy of either beta blocker, nitrates, enalogene, or calcium blocker, and unless they have severe ischemia, the idea is that maybe this patient should not be scheduled. So we went through that problem that many people trying to say that we don't want to do cases, and but everybody learned very quickly that these are the must. So the try medical therapy, fail, then they come. So we have the whole algorithm, and I can put on the website about it that how we were able to get this in less than 2 to 3% over right from 2010 when people are still thinking about how to do it.
Does an effective heart team helped also?
No, that's actually the the editorial by Spencer King is the kind of little contradictory of the appropriateness and heart team, because that is the sometimes heart team may think about that should be done, but if your case may be inappropriate by the by our OC criteria. So those are two different things in my opinion. But yes, many of these cases are discussed once they are complex. But once they are complex, they make it for appropriate use anyway. Appropriate use is mostly for your classical mid-LAD, mid-RCA, diagonal 70% lesion, who is a not medical therapy, has a mild ischemia. That's the inappropriate, and that is where the whole question came. And we know with George Bush, our former president, that he had a calcium score positive and led to the stenting, and the whole the discussion by Dr. Steve Nissen and so that is what we need to avoid. And in some cases, when there is a diagnostic dilemma, you need to do a FFR. So therefore, then once you did FFR less than 0.8, irrespective of medical therapy, based on the FAME2 trial has shown to be beneficial. So that's your best defense, unless it's a 90% lesion or patient has severe ischemia.
Just to go over how the system works in the Sinai cath lab, every patient that's scheduled will, our nurse will call, or we have our schedulers who will call and get some kind of a pre-testing test, whether it is a CT scan, PET scan, or a stress test indication for cath. Once the cath is done, the fellow and the nurse practitioner or the cardiology fellow who is in the room will, we have the clinicals, but everybody's syntax score will be entered, and before a PCI is done, we have to make sure they are appropriate. We have the appropriate grid that will pop up, and if we know it is inappropriate, which means we have educated all our fellows and the nurse practitioner and even the nurses in the room, they all know what is appropriateness criteria. Every room you will see that has this the color graph. And if it's inappropriate, of course, all the faculty goes by it, and all the visiting doctors, the fellows will be involved. If it's inappropriate, it will be discussed with the senior faculty, which is myself or anybody else who is around. And inappropriate cases, will be taken out of the room. Like mentioned, will be this mid-LAD, mid-RCA, PDA, diagonal, this kind of disease, and borderline cases. And when in doubt, and more important is most patients who have come with a CT scan. This is a very common scenario. Patient asymptomatic, going for some kind of a test or something, and then had a CTA. Now you find 3-vessel disease. Question is what to do. Whenever in doubt, the best defense is do an FFR, and then you know that if it's physiologically positive, then you go ahead with the PCI. This criteria is strict, and if we think questionable, we will not put a stent, they will get medical therapy.
And that is the key crux, that every case will be evaluated before stenting into that grid. Because remember, the outside, when you schedule the case, everything is okay until you do angiogram. So because one part of the appropriateness is how many vessel disease and where the location is. So all put together, this system which has been created has really helped us to get to this. Now, if we can just show, and I'm going to finish this one very quickly. You see here now, we have put a stent, and you can see that there is a little bit of outside in the mid-RCA, little haziness. That is that tortuosity which the wall will fall off on the stent. So not to worry about. There's not a perforation. It's the normal tortuosity where the stent has been placed, and excellent results. No need to post-dilate. Post-dilatation might even harm in this particular case, and we have prepared the lesion very well. Excellent results. TIMI-3 flow, one long stent of the Promus element has done a great job. So I can sum up now, if we can go back to our slides, the take-home messages, the LV support during high-risk PCI using Impella, and we'll do in this particular case LAD now, offline, that high-risk PCI using Impella seems to have advantage, transfer lower MACE or IABP, but is associated with higher vascular complications, higher sheath size because 13 or 14 French in Impella versus 7.5 French for balloon pump. The role of both Impella or IABP in cardiogenic shock in the shock trial, and so despite their ubiquitous use, is questionable and cannot be supported by published data. Interventionalists have to take the prime responsibility of following the appropriate use criteria for PCI and use stents only in appropriate clinical and angiographic scenario. Very, very important. We as societies can do the work, and so, but we had to take the stand on it that we are doing the right thing for the right patient. Now, 3 quick questions. Which of the following statement is true for Impella versus balloon pump in PROTECT 2 trial of high-risk PCI? Impella use reduced mortality, Impella use decrease MI, Impella use decrease CVA, Impella use decrease vascular complication, and Impella use decrease TVR. So the one of them is the wrong answer, so that, correct answer, you have to answer it. Second, as per ACC NCDR data, what is the range of PCIs classified inappropriate for the stable CAD at the present time? Is it less than 5%, 5 to 10%, 11 to 20%, 20 to 30, and more than 30? And the last question is, following characteristics are associated with higher inappropriate PCI use in stable CAD patient with the Chan's article which I talked about. These are either white race, female gender, urban hospitals, commercial insurance provider, or lower baseline hospital PCI volume. So which case will get and does not get the inappropriate PCI? So you need to answer, and of course all the will be available on CardioSource website.
Samin, superb case. I thought it was a very practical and useful demonstration of inserting of the Impella, and just a brilliant use of rotational ablation. The decision pathways to undersize to the 1.25 burr, to persist with it, to eliminate the wire bias, to increase the speed. Excellent illustration, Anu. Final points from you, and I'd like to also know what are your plans for the LAD? We are planning to do the question is, do we do the LAD today or the CIRC today? We are going to do another vessel once we already have the Impella on board for this patient. This requires rota and bifurcation stenting. I think we'll do the CIRC today, and then later on we'll bring her back for the LAD diagonal PCI. Finally, the same, we have demonstrated how to do these tough cases as far as coronary wise, but I always give credit to my fellows who work here day and night with us, that these kind of tough cases will not be possible without their help, especially having shown that when you have a larger sheath, you need a good, what is called as
the femoral device, closure device, the technique that, and they are all trained and they do the best. We have our 3 fellows right behind me, who is Bhupati, who will be finishing his training and going to India. I have Rahul, who has come from United Kingdom, will be trained and going back there. And then I have Taj, who is going to be staying in United States. They are the one now taking care of the next part of the complexity of this case to do the groin closure.
All right.
Congratulations, Samin. Excellent review. Greetings also from our websites to Dr. Christopher Neighbor in Essen, Germany. We'll see you for the next session, number 53, on November the 19th.